Ultimately, the STAMP trial is trying to reduce unnecessary deaths from TB among HIV-positive patients. About a third of HIV-positive patients die because of TB, and in half of these, they have not been diagnosed by the time they die. We diagnose TB by looking at chest x-rays, and also we ask patients to submit sputum samples and we test those samples for TB. That system relies on the patient having a strong immune system that is fighting the tuberculosis for us to have these telltale signs that we can use to make a diagnosis. Now, in HIV patients, their immune system is weakened and will not adequately fight the tuberculosis enough to produce the signs that we're looking for when we want to make a diagnosis of TB. And also signs like cough, fever, and weight loss, they're too vague in HIV-positive patients for them to support a diagnosis of TB. And even if the patients are fighting the tuberculosis adequately, they may be too weak to submit a sputum sample. So relying on sputum testing alone is difficult. Starting patients on TB treatment without a definitive diagnosis is a problem because the actual illness that they have may go undetected and untreated. TB treatment takes a long time to complete, about 6 months, and it is also toxic. Patients may unnecessarily be exposed to these medications. With HIV-positive patients who are on drugs for their HIV, TB drugs can limit their effectiveness. This will complicate our treatment of HIV.
We linked up a team at Zomba Hospital in Malawi and another at Edendale Hospital in South Africa to trial some new urine tests for TB to see if they could diagnose more TB than the sputum tests currently used. The ultimate aim is to reduce deaths from TB and HIV. Because TB is common but hard to test for, doctors often treat patients for TB without a positive test result. That's why we didn't know if the new urine tests would have an impact and needed to do a trial. We recruited 2,600 patients in total, an equal number in Malawi and in South Africa. In both hospitals, we randomly assigned half the patients to sputum testing only, the first study arm, and half the patients to both urine and sputum testing, the second study arm. For us, it was important to run the studies in both Malawi and South Africa, as the settings and the hospitals are quite different, and the levels of TB may vary. And we wanted our findings to be applicable to more than one country in the region.
What we have experienced is that most of these patients are very happy to get tested for TB, especially when you are using urine, because in some cases they can't cough. But when we say we will be testing using urine, they were more than happy to have this test done.
We used 2 different urine tests. The TB Lamb test, which costs only $2 to $3, that one's simple enough to be done at the patient's bedside. And the Gene Expert test, which is done in a lab, but most hospitals already have the equipment and know-how, as it uses the same techniques as testing sputum for TB.
I have 3 samples here. The urine sample, which I will run TB Lamb, and also I will spin it to do a Gene Expert test. This is the sputum. I also do a Gene Expert. So I will start with the TB Lamb. So I transfer this to the TB Lamb strip. It will take 25 minutes. Now I will prepare my sputum. Take out to male. I will transfer some of the solution into this GeneXpert cartridge. Then I close. 25 minutes have gone. As you can see, the strip, there's a line on the patient window which shows that this result is positive. This is a printout result from the GeneXpert. The results show that the Mycobacterium tuberculosis has been detected. So it's a positive result. So this has to be communicated to the clinicians so that they can start the patient on the treatment immediately.
We gave the TB test results to the doctors who decided whether to treat the patients for TB or not. To create a common baseline, there were no other differences in the type of care the patients received at each hospital. We then compared how many patients were diagnosed and treated for TB in each arm of the study and how many were still alive after 2 months. The results showed that the patients in the urine testing arm were less likely to die within 2 months, but this benefit was only reliably seen in the sicker patients who had more advanced HIV infection. Screening for TB with urine tests reduced mortality by 20% in patients with low CD4 cell counts and by 23% in patients with severe anemia. That means for every 100 patients with HIV admitted to hospital and screened using TB urine tests, we could save around 3 lives. Urine testing also diagnosed 50% more patients with TB than sputum testing alone. Importantly, this benefit is not just restricted to the sickest patients, but is seen across all patients in the study. That means screening 100 patients with urine tests will diagnose approximately 7 extra TB cases. We also compared the extra costs of urine screening to the benefits of saving lives and treating more TB. And we found the benefits outweighed the costs.
We're very excited by our results. It is one of the first trials to reduce deaths in patients admitted to hospital who have HIV and TB, a co-infection that killed around 400,000 people worldwide in 2016. So what our results boil down to is, if in places with a high burden of HIV and TB, we do TB urine tests on all HIV positive patients admitted to hospital, we can diagnose and treat more TB and ultimately save more lives in our sickest patients. Happily, the urine tests are cost effective, and so we strongly recommend a change in TB testing practices to include urine-based tests.